Bismillahirrahmanirrahim. Good afternoon, everyone. Assalamu alaikum. I hope you're all doing good. For those who don't know me, my name is Dr. Rabia Shah. I'm a specialist pediatrician working in UAE, and I'm one of the clinical mentors working in MedPrepOnline. Okay, so I hope you're all doing good. Actually, I understand that there are some candidates face a lot of difficulty in clinical stations like neurological system because it's a very complicated one. So I wanted to take this opportunity to simplify one part of it for you so that you can generalize the approach, and the goal is actually to make things hopefully inshallah easy for you. Okay, so we will start with with one of you volunteering for one clinical station, and then we will discuss approach for that station if it ever comes, and then we'll have a short discussion on the case. Okay, so do we have any volunteers for now? Anyone? It doesn't matter how, I mean, if you guys think that you will not do well, it's all about practice. The aim is to correct our mistakes and to focus on the fact that, to overcome our mistakes before we sit in the exam. So a volunteer would be really appreciated to have a start. Otherwise, the fact is we can start like that, but if we do a clinical case and then take it from there, it would be much better. No problem, Dr. Matayab. Anyone else? Dr. Amir, Dr. Myra, Dr. Nuzat, Dr. Sajjad. Okay, Doctor. Who wants to do it? You can just unmute and we can start.
Thank you.
Okay. Thank you for volunteering. Can I have your good name, please?
My name is Jessica.
Jessica. Okay, Dr. Jessica, good to have you here. We will start with a clinical case, which is one of the commands for a case of ataxia. It could either be a difficulty writing, it could either be difficulty walking, difficulty in keeping balance. So we're going to start our case now, and whenever you're ready, we'll set the timer and then we'll take it from there. Okay?
Okay.
Let me know when you're ready.
Okay, I'm ready now.
Okay, just give me a minute to set the timer. Okay, your time starts. You can start your station. Hello, you there? Okay.
Yes. Is it a history station? I can't see any question.
It's a clinical station. It's for clinical examination. You usually don't have a huge stem in clinical. You just get a command, okay?
Okay. So
Yes.
I come in, I greet the patients and the relatives, if any, then take permission. I'll clean my hands. Then I would start by asking, it's a neurological question, so I'll start by asking the mother if the child can walk. Then I would ask the...
Okay, you're asking the mother if the child can walk, correct?
Yes, yes.
Yes, he can walk.
Okay, so I would want the child to walk for me up to the wall and come back.
Okay. When the child is, the mother tells you that when he walks, she has to hold his hand. When she's walking, it's a girl actually. When she's walking, she's walking with feet apart, with like legs apart, and then she's not able to maintain her balance.
Okay. Then I would ask if she cannot maintain her balance, and I would also want to ask if the child can do a tandem walk for me.
Tandem walking is also with too much difficulty.
Okay, so that means the child cannot run too. So I would do a general observation, looking at if there is any surgery like tendon release, any hypertrophy, any discoloration, any then I also look around the room to see if the child have come with anything like a wheelchair or a walking stick. Then after that,
Yeah, there is a wheelchair lying in on the side in the corner in a room.
okay, there's a wheelchair. Then I would want to know if there are other things the child is with, like is it orthosis, like a boot kind of they wear to support their balance. Okay. Then after that, I would want to start with the lower limb examination. I would want to test for power.
Okay. How would
Power
you
in
do it?
lower
Could
limb.
you explain? Could you explain each step while you're
Okay,
doing it?
yes, I would ask if the child can lift up the legs
Okay. He
against
can.
gravity.
She can lift up the leg. Yes.
Okay, if I add pressure, can it sustain the pressure?
No, not with pressure.
Okay, so that means power is at least 3. Is it in both left and I'll do for the left and check for the right limb,
Both.
lower limb?
It's the same on
Both?
both sides. Yes.
Okay. Okay, both on the lower limb. Okay. Then I would do tendon reflexes.
Okay.
Yeah.
So
For the both lower.
the reflexes are decreased. Reflexes you cannot elicit. They're very much decreased.
In both lower limbs.
Both lower limbs. The knee reflex you're trying to do, right? So that is decreased.
Yeah. Okay. Then I want to check the tone too.
The tone is slightly increased.
Increased.
Yes.
In both lower limbs.
Both lower limbs.
Okay. I would want to check for sensation.
Okay. How would you check for sensation? Which sensation are you checking?
I'll use a cotton wool to check if the child can feel as I touch. Yeah.
Okay, so it's slightly he cannot appreciate.
Okay. In both lower limbs.
It's decreased. If you compare with another area, it's less.
Okay. Then I'll want to do clonus.
Okay. Clonus is not there.
Okay, absent. Then Babinski sign.
It's upgoing.
Upgoing.
Yes.
Okay. Then that's for lower limb. Then should I go ahead and check the upper limb?
Yes, you still have a few seconds. Go on. Do relevant examination according to your findings.
Okay, so I'll also check for power in upper limb.
Okay. It's same as upper limbs, decreased with resistance.
Okay, so at least 3. Then what about reflexes
Reflexes are decreased.
and tone?
Tone is slightly increased.
Okay, sensation?
Sensation is the same in lower limbs, slightly decreased. Okay, your time is up. How would you like to finish your examination? Anything else that you want to finish up to?
Yeah, to complete my examination, I would want to do cranial nerve examination.
Okay.
Then I would also want to do
Okay. Okay, present your case.
Okay. Sorry, I didn't get the age of the child.
She's a 15-year-old child.
Okay, 15-year-old.
Girl, yeah.
Okay, 15-year-old female who presented with history of I remember the history, ma. Let me say my findings on lower limb examination. There is hyperreflexia, positive findings of hyperreflexia. There is power is at least 3 in the lower limb, and reflexes are exaggerated, same as upper limb. Power is at least 3 with hyperreflexia, and tones are reduced.
Okay. What is your diagnosis?
CP.
Okay, which type of CP?
Spastic cerebral palsy.
Okay, anything else that comes to your mind? Okay, how would you like to take it from there? How would you investigate and how would you manage?
Okay, investigations. Management will involve a multidisciplinary team, and I would want to look at the previous notes of this child. Then
okay, how will you manage?
Okay, multidisciplinary team management. I would want to involve the neurologist, pediatric neurologist. I would want to involve the SALT. I would also want to involve the orthopedic surgeons and community pediatrician. Then I would also want to do investigations like
Okay, okay. Thank you, Jessica. Thank you for your attempt. Anybody has some feedback or anybody wants to revise the findings in this case and anybody wants to alter it in some way or give any feedback?
This young woman displays a characteristic wide-based gait requiring assistance to walk.
I will show you a video of this young girl, and then if anybody wants to perform it in another way, let me know. Okay, thank you, Dr.
Ma'am, can I summarize it a little bit?
Yes, please.
Okay, ma'am. So the command is to check the gait of this 15-year-old boy or female. Yes. So first of all, I will make the child walk to look for the gait. Then I will do the motor examination, especially the bulk nutritional status of the child, then the tone, power, reflexes of the child, and then do the planters as well. Then moving upward, I will do the superficial abdominal reflexes of the child. Then I will palpate the bladder of the child.
Let me tell you the gait findings. Let me tell you the findings on the gait, and then you can tell me. I will mute it for you. And so this is the gate. Can you guys see?
Yes.
You all can see? Or not yet?
No, the video is pausing.
Can you see the gate?
Yes, it.
Dr. Shahzad?
Yes, the video is pausing for me, but I can appreciate that it is Ataxia gate, I think.
Okay, okay. So now tell me, how would you examine this child further? This young
So
girl
after
further?
this, after examining the gait of the child, I will make her lie in the couch and then look for the tone power reflexes and planters of the lower limbs. And after that, I will check in the abdomen, especially palpation of the bladder and back, as well as the superficial reflexes of the abdomen. Then I will also do the cranial nerve examination, and then I will look for the cerebellar signs, in which most importantly the nystagmus, the dysterokinesia, pendular knee jerk, and then I will also look for any signs of meningeal irritation.
Okay. Thank you, Dr. Shahzad. Thank you.
Yes.
Okay, thank you, Jessica, and thank you, Dr. Shahzad. Good attempts by both of you. So let's shed some light on this case that we are talking about, okay? We will do that next. First, we will discuss how to approach a child who comes with a command such as an unstable gait or difficulty walking or anything like that. And especially if you make the child walks like this, okay? So first of all, tell me, Dr. Shahzad and anybody else who is available to participate, when you see when you are asked to do the gait examination or do any relevant examination having the history that the child has an abnormal gait or an unstable gait, and if the child walks like this, what differentials come to your mind, first of all?
I would think about Frederick ataxia.
No, like the broad differentials, like pathology,
Infection,
not
post-infectious.
diagnosis. No, pathology in general terms, what is involved? Which part of the central nervous system is involved, or which part of any system is involved? Number one is cerebellum. Good. What could be the other source of pathology? Sorry? Is someone saying dorsal column? I don't hear it. Okay. Your voice is not very clear, but I think you guys got it. What I'm trying to say, the pathology it is an ataxic gait. It is a broad-based gait. Okay, simply what we call it like a drunken gait or a broad-based gait, because they are unstable. They cannot walk with their feet close together. They have to walk with their gait very wide to keep their balance. Okay, number one. So once you come across an ataxic gait, you immediately know that this pathology, yes, proprioceptive problem, very good, Dr. Nozit. So you know that the pathology is either in this, it's in the balance, okay? So what is the pathway for the balance? The pathway for the balance starts with proprioception, which is actually the position sense from your skin and from your feet, and it travels from the spinocerebellar pathway, goes to cerebellum, and that is actually the center of the for the balance, and this is actually how the balance is kept. Okay, so you know that there is something wrong with this whole pathway, any part of pathway, but this pathway. Okay, so once you come across any unstable gait, then you need to know how you have to how to approach it from there. Okay, first of all, I would give a very brief feedback for Dr. Jessica's examination. Number one, I might not have heard you properly, but I could not hear your introduction or consent or your general survey you did, but that was after you checked the gate. general survey of the child, whether he's alert, whether she's conscious, alert, any distress, any dysmorphism. None of these features you ask. That is actually, like, the most mandatory, the most basic part of your clinical examination, to have a general screening look at the child as well as the surrounding. It is very, very important, and you should give it half a minute at least, okay? Let me tell you why. So once you enter into a clinical station, okay, this is supposed to be a real station. You're supposed to come across a real child. And I mean, you've just stepped into this environment, and you're given a command. So you need some time to compile your thoughts, to compile your thoughts about how you're going to approach this case, okay? So the first thing, of course, after introduction, cleaning your hands, taking consent, is just stand back from the child. Don't approach the child immediately. Stand back from the child and have a very good look at the child for at least 30 seconds, okay? You have to have this zoomed out look at the child, because there are many things that if you do not notice it now, you will forget about it later, or it will slip from your notice later, okay? So it is very important that you step back. You have a general, it gives a very good impression to the examiner as well. I always tell this to my students. It gives a very good impression. Just stand back, look at the child, look at the surrounding, and then you enter and you engage with the child first. Okay, talk to the child. If you know that this could be a neurological case, the first thing, or even not a neurological case, any case, endocrine case, metabolic case, anything, you want to know the general mental status of the child first, okay? So once you, and engagement with the child is very, very important, because the child has to feel at ease with you. This is actually a young girl. She's not a child, but it could be a 3-year-old, a 4-year-old. So it gives two benefits. Once you're making the child comfortable, you're gaining the confidence of the child. And then at the same time, by asking some age appropriate questions, like what grade are you in, or any questions, in age appropriate questions like that, with engaging with the child, you can get the mental status of the child, whether this child has any gross what do you call it, gross learning deficit, okay? Is that clear? So the first and foremost thing for all clinical cases is to stand back, have a general survey of the child. So what are the things that we will be observing from a zoomed out perspective? Anybody, you can write in your chat, you can just unmute your mics. It's an open discussion going on, okay? So what are the things you will
you'll be looking at the child's gaits, the muscle bulk, if there are
the child
wasting.
is sitting. She's not walking, she's sitting. What will you notice?
I'll be looking at the posture, if there is wasting, asymmetry, if there are any fasciculation, any skin rash or scars on the leg, like tendon release, dysmorphic fascia.
Any abnormal features, any microcephaly, macrocephaly, any thing of that sort, any abnormal movements, okay? Maybe their child has some abnormal choriothetoid or any tremors going on, okay? So these are the things we will look for. General posture of the child, if the child is holding his hands or his legs in any specific posture, okay? Everybody clear about this? So the first step, let's take it to the first slide. So general inspection, it's very, very important, okay? Conscious level of the child, whether there is, and once you are engaging with the child, you're talking to the child, so you know that it is an unstable gait, so you have this ataxia diagnosis in your mind. So you will speak to the child and you will notice any dysarthria, okay? And orientation by asking age appropriate questions. After that, alertness, whether the child is alert, oriented in time and space, or are there any encephalopathic features, okay? Any abnormal movements, any obvious asymmetry, any head tilt, okay? To pick up any cranial nerve pathologies associated with the cerebellar pathologies. Any failure to thrive, okay? It could be any chronic disease leading to failure to thrive, having multiple reasons. For example, ataxia telangiectasia, in which the child has chronic problems, and it could be cerebral palsy, in which the child has feeding difficulty as well, so he or she is not thriving well, okay? Any obvious developmental delay, any walking aid next to the child. So these are certain things that you will screen or scan scan on the general survey of the child, okay? And then you're looking at the skin for different things, like for any neurocutaneous stigmata, any rash, any telangiectasias, you will be not noticed from a far away, from a zoomed out perspective, but when you're looking closely at the child, okay? Everybody clear up till this point? So what after that? If the child has abnormal gait, what is the second thing that we will do? Anyone?
Tell him to ask to walk tiptoe, heels, and
Yes,
tandem.
yes. Ask the child, or if she's a big girl, the parents if she's a child, or the big girl if she's like not a child, and then you will ask if she can walk comfortably. Okay. So, if you feel like the child is not walking comfortably, what is very important thing to do that Jessica did not mention that she will do? It's an unstable gait, so what will you make sure? What is going on in this video? Is the child walking alone?
No support.
You have to
Yes,
support the child.
yes, very important, very, very important. Child safety is the most important thing. Okay, so if you say, have the stem with you that the child has an unstable gait, you will stand near the child and you will ask her if she is able to walk. Once she is able to walk, you will put both your hands around her, not touching her, but make sure she doesn't fall. So you will be walking besides the child, and you will have both hands apart from the child but on both sides of the child to support him or her. You got it? So you're walking beside the child. So what is the how do you if you have any abnormal gait station, then you have to do very important, you have to do all the gait maneuvers, okay, as much as you can, okay, very important. If you have any abnormal gait, remember this thing. If the what are the scenarios in which you will do all the gait maneuvers? Number one, if the command is gait examination, number one. The second is if you make the child walk and you feel that there is abnormality in the walk in any way, it may not be easy for you to guess. It may be easy for you to guess, but you have to make the child do all the walking maneuvers, okay? Because suppose if this child has ataxia, all right, now, this child could have ataxia due to which pathology? Number one, it could be cerebellar, it could be sensory ataxia. Understood? So, for sensory ataxia, you have to do all the gait maneuvers to make sure that the child has any other task performance difficulty. Okay? I will not go into the detail of gait maneuvers because that is not the scope of the session today. We're basically focusing on cerebellar examination, but I'll just enumerate them to you. You do the simple gait, followed by which, first of all, if you pick the pathology, if like you pick the abnormality, it is ataxia, then you have to do the one that is most important. So if an ataxic gait or a broad based gait, which is the first maneuver you will ask the child to do in the gait? Tandem walking, excellent. Tandem walking and turning immediately, okay? So you will ask the child to do tandem walking. Now, very important, especially in neurological cases, not in other cases. This respiratory and cardiovascular, these cases are different. Just as a very general tip in neurological cases, that if you have to do, you want to do, also musculoskeletal cases, if you are asking the child to perform some task, don't tell him to follow you. Always demonstrate, and I mean, don't give instruction and tell him to follow. Always demonstrate and tell him to follow, okay? So once you're doing the tandem gait, you are asking the child to do tandem gait, you have to do it yourself to save time. Don't say, can you walk like, you know, one foot in front of another? The child will take 2 minutes in understanding your instructions and your time is gone. So don't waste your time in things like this. Walk in tandem gait. Walk like that look at how I am walking. I am putting both the feet in front of each other. Do you think you can do this? Okay, so always demonstrate and make it like a play for the child so that he is able to follow you. You're not dealing with an adult, you're dealing with a child, so make it like playing so they can engage. You can get their compliance, okay? So always do it first. So the first thing that you will do in cerebellar examination is tandem walking. Okay. So tandem walking, I will show you a video of all of these. I'm just telling you the general steps right now. Okay. So you will ask the child to do tandem walking, and then you will ask him to turn around quickly. Okay. And then quickly, if you have time, you will do other quickly, like tiptoe walking and going, and then heel walking on coming back. Okay. And then what we call the fog test, in which the child, you are asking him to stand on both lateral sides of the feet, walking and then coming back with a different maneuver. So just to save time, how much time will it take? It will take less than 10 seconds or 15 seconds. Okay. So tandem walking, like you do one task in while going in one direction, and when you're coming back, do another task. When you're going again, like back and forth, do one task and another task. So all the tasks will be done in no time. Okay. So after gait, what will you do after gait?
We'll do the Rombergs
Rombergs,
because
yes.
he's
But
standing.
just so that you don't miss it, always I tell my students to, attach these two things so that you don't miss it. I'm sorry? Your voice is a bit far. Okay, anyway, so always when you're doing the gait, tie one thing to gait. What is that? Gower sign. Okay. Once you're doing the gait, make the child squat and stand, because the gait was going to be over. You're going to make the child sit or even lie down. You cannot make the child stand up for Gower sign again. It is very, very unprofessional, and it gives a very bad impression. So always remember, in your examination, once your child is in one position, like the child is standing or walking, make sure you do all the examination steps that you are supposed to do while standing or walking, and then you make the child sit. You don't want to, the last thing you want to do is make the child sit, do some maneuvers, and oh, okay, I forgot to do Gower, because you just picked that there is some hypertrophy in the calf muscles. You're making the child stand up again and do Gower now. Okay. So do in a very smooth way all the steps that need to be done in one position. Do that, move the child to the other position, do all the steps then, and then if the child needs to lie down, make the child lie down, and then do the steps. Very, very important. This is a general approach that you should remember in all cases. And I will only show you cerebellar case right now. But what you're going to do today, homework for you guys, is that you will, make a scheme or make steps for your stations, for your all examinations, in such a way that you know that when the child is standing, I will do these. When the child is sitting, I will do these. When the child is lying down, I will do these. Okay. So once the child is, as I told you, the child is standing and you're doing the gait examination, the other important thing with the gait examination, quick Gower, sit and stand. Can you sit and stand? That's it. Okay. So so what is the, what do you call it? The abnormality you will pick in sitting and standing?
To look for Duchenne muscular dystrophy.
And another thing, Duchenne Gower sign is positive when the child can squat and not stand. What is the pathology in which the child cannot sit? Peripheral neuropathy. Okay, very important. Everybody knows about Gower, but they don't know that there are two purposes to do sitting and standing, squatting and standing. Peripheral neuropathy children cannot squat. Muscular weakness children cannot stand from squatting. They will squat, but they cannot stand. Okay. This was something out of the context, but just something for you guys to know. Okay, after that, we will do Romberg. So what is Romberg test? Anyone? What does it differentiate? You have ataxia.
Sensory and cerebellar.
You cannot perform tandem walking, heel toe walking. You are confirmed that it is it. You have confirmed that it is ataxia. Now, what is the purpose to do Romberg test? If it is ataxia anyway, why would you do Romberg test? Anyone?
To differentiate between cerebellar and sensory.
Good, excellent. How will you differentiate?
If you tell the patient to extend his hands and then tell him to close his eyes, and if he is going to fall, that means he has some problem with the sensory.
Okay, excellent. All right. So in cerebellar ataxia, Romberg test will be positive or negative? Someone tell me.
Negative.
Negative.
It will be negative. Excellent. Okay. It will be negative because in cerebellar pathology, the proprioception and the position sense is working completely fine. So that will not be positive. So what is Romberg test? For those who don't know, I will repeat again. In Romberg test, what you do is you ask the child to stand straight with feet completely close to each other, no gap between the legs. And then you ask the child to either extend his hands forward, arms forward, or maybe even lying on the side of the child, just to test his balance while the child's eyes are closed. Very simple. Okay, so what happens when the child closes his eyes? When the eyes are open, he's using his visual skills to maintain his balance. Like he's keeping an eye on different things and he's trying to maintain his balance. Once you ask the child to close his eyes, the position sense in the legs should be responsible for that. But once there is sensory deficit, there is sensory loss, there is sensory ataxia, and once the visual stimulation or the visual input is on, the child will not be able to maintain their balance and they will fall. Okay, so this was about the Romberg test. All right, so while the child is still standing, what is the next step that you will do? Back examination, very important. In neurological examination, I always say pair gait, gower, and back. So GGB, or however you want to put it, or GGS, spine. Okay, because spine is again another thing that if you have scoliosis and you miss it while standing, then you cannot make the child again to stand for testing scoliosis. So while the child is standing, how I will put it like this. So child while standing, while sitting, and while lying down. Cerebellar examination, you should always, or ataxia examination, you should always distribute in these three. So while standing, you do the gait, you do the gower, you do the Romberg for, of course, for ataxia, and then you check the back quickly, okay, for any scoliosis. So now I will just close this and test you guys. Scoliosis, if present in ataxia, what differential will come to your mind? Anyone? Okay, it's Friedreich ataxia. Okay, always remember. Or even ataxia cerebral palsy. Sometimes scoliosis can present in cerebral palsy as well. Now we did the standing maneuver. So who can tell me again what will you do after general observation? What will you do while the child is standing? Just enumerate them to me. Anyone?
Gait.
Gait, number one. Then
you check for the goers.
Gait, gower, Romberg, and
Romberg.
spine. And
Yes,
spine.
fine.
Excellent. Okay, so you guys are awake. Okay, now sitting the child. Okay, so then you know how smooth your examination is going now. You picked up an ataxic gait, you checked the gait maneuvers, you confirmed that it is ataxia, you did Romberg just to make sure that it is positive or negative to broadly categorize your ataxia, whether it is sensory, whether it is cerebellar. Okay, because the pathologies and the differentials are completely different. We will just come to that. Okay, and then you checked the quickly scanned the back, the spine for any scoliosis, and now you've made the child sit. Okay, so after making the child sit, you're sitting in front of the child, and now you're looking at the child from close view, and you're scanning the child's face again for anything that you missed from far. So what is the first thing that is relevant in ataxia, and you need to look in the face of the child? Anyone?
Telangiectasia.
Telangiectasia is excellent, number one. And anything in the eyes?
Nystagmus.
Nystagmus. Okay. So what is the type of
Hinder
nystagmus in
ears.
ataxia? What is the type of nystagmus in ataxia?
Horizontal.
First of all, tell me nystagmus is present in which ataxia, cerebellar or sensory? Because once we are doing this examination, we are differentiating our cases, right? On the basis of Romberg test, we differentiated whether is it sensory or cerebellar. Now, on the basis of nystagmus, we will again differentiate. So, nystagmus is present in which ataxia?
Cerebellar.
Cerebellar. Excellent. And which type of nystagmus it is? It is called
Horizontal.
what is it called? Gait evoked nystagmus. Okay. gaze evoked nystagmus. So what happens is you will ask the child to, you're sitting head shoulder level with the child, okay? Always remember, because it is very unprofessional that you've made the child sit and now you're standing and doing the examination. So you grabbed a chair for yourself and you're sitting with him just to make him comfortable and perform your examination with more ease, okay? So now you're looking at the child, you look for any telangiectasias, which would be present where? In the conjunctiva. They would be present in the earlobe, they would be present on the nose, in where we have the thin skin, okay? That is done. Now you're looking for nystagmus. So nystagmus, it's actually gaze evoked nystagmus, in which what happens is you will ask you are sitting in the level of the child, you have an object, a shiny object or a colorful object in between your eyes and the child's eyes, and you're moving it to peripheries of his vision, okay? So once you move the pen like on each side laterally or even up, the child will start having nystagmus. Now there's even a normal nystagmus, a normal variant of nystagmus that is present, but it is present on a very extreme of vision. Like when you move your eyes completely laterally, then a slight nystagmus is there, but this one is more pronounced and it can be elicited sooner. Like just when you move your peripheral, the object from the vision from central to laterally, it will elicit nystagmus. Okay, so this is in the face and eyes. Now what is your second step? So from face, you're coming down. So what else do you need to check while you're sitting, and what else comes to your mind? You have ataxia.
Limbs, starting from upper limbs.
Upper limbs, excellent. So what do you want to check in upper limbs?
Dystiadokinesis, any tremors?
Dystiadokinesis, number one. Past pointing, excellent.
Pointing.
Number two, there is one more. Okay, but these two are more important. So if you do these two, it's enough. So in upper limbs, you do number one, rebound phenomena. We'll just discuss with that. So in rebound phenomena, it's nothing. It is just you ask the child to stretch his arms and then you push it down. And once you lose the pressure, you let go immediately. The rebound, it's as evident from the name, rebound phenomena. If there is any cerebellar pathology, he will not be able to sustain his motion much, and the rebound will be very severe, like the hand will go up immediately and with great force. This is called rebound phenomenon. Okay, now the second is hypotonia. Also it is present in cerebellar examination, cerebellar pathology. The second is coordination. Intention tremors, yes, intention. So finger nose test, coordination. How do you do coordination? So coordination is actually tested by doing any complex movement, like or dystiadokinesia, in which you do rapid movements in repetitive manner to see if the child is able to do it. So how do you do dystiadokinesia? Can anyone tell me?
Coordination is
rapidly do the pronation supination.
Yes. Okay. Now, what are the two signs that you will get in the finger nose test?
One, he won't be able to do it. He will be past pointing.
Yes.
He will
Number
always
one is
lose
past
the.
pointing. So there are two features. Number one is past pointing. Past pointing is that the child, you'll ask him to touch his nose and then touch your finger. Okay, again you have to do it yourself first, because this is a difficult command for children to follow if they haven't been doing it for a long time. Okay, so past pointing, again demonstrate first and then do it yourself, and then ask the child to do it himself. So past pointing is the child will not touch your finger and the hand will go past your finger, because he cannot coordinate, he cannot, his judgment is lost. Okay, the other is intention tremor. Intention tremor is different from past pointing. Intention tremor, what happens is once his finger reaches the object is what? Your finger and his nose. So once it reaches near his your finger or his nose, he will start moving it back and forth. This is called intention tremor. Okay, I'll show you videos of all these things, don't worry. Now, while the child is sitting, what else do you want to do? From face, upper limbs, and now knee jerk, better to do in sitting or lying down? Anyone?
Sitting.
Sitting is better actually. You can do it in both positions, but sitting is better. So pendular knee jerk in sitting. How do you do knee jerk? You always remember, expose the tendon first. Feel the tendon, hit the tendon, and see what? What are you supposed to check?
On the knee, above the knees, the muscle twitching.
Yes, very important. So when you are exposing also the muscle that you need to check. So the muscle is which? The muscle is actually in the, what is it called? The muscles in the thigh. It's not the leg muscles, okay? So you expose the knee all the way from the, like you expose the muscle all the way above from the knee. You feel the knee tendon, you hit it, and then you're looking for muscle contraction in the thigh muscles, okay? Because knee jerk is more pronounced, so the movement is there, but you actually, this is the standard way of doing any reflex, because in some the movement may not be there very much, but the muscle contraction you will be able to appreciate, okay? So this is just a general guidance on how to do any any tendon reflex, okay? Okay, so these are the maneuvers you will do in sitting. Face, eyes, nystagmus, upper limbs, rebound phenomena, finger nose, dysdiadokinesia, and quick check the hypotone. Then knee jerk, and now ask the child to lie down. Once you ask the child to lie down, what will you do? Most importantly, quickly check the tone and then do heel shin test. So again, doing the heel shin test, it is very important that you pick the child's leg first. You have to tell him, because otherwise he will not follow. So you are going to tell him that I'm going to move your leg and I will ask you to repeat it after me once I stop, okay? So you will pick up the child's leg, you will touch his heel with the knee of the other leg, you will slide it from the knee to the foot area, and then you will pick it up, like make a D, okay? Pick it up and bring it towards the knee again. Now again slide it towards the foot, pick it up, touch the knee, slide it towards the foot. So you do it 3 times, and then you ask the child to repeat after you. Okay, so by the end of 6 minutes, you would have done this much. Okay, then your time will finish. Just give me a minute, please. Okay, so once your time is finished, maybe you would have done up to this much. There are, of course, other relevant examination that you need to do, but it is not possible that you would have done it. You can be able to do it in these 6 minutes. If you are super fast, you can also do other, other neurological examination of the legs. But these are the things that you at least should have done by the end of 6 minutes. Okay, so what are the relevant examinations that you will do after doing this? Okay, so number 1 is cardiovascular. Excellent. What would you do in the examining the cardiovascular system? For any myopathy, any cardiomyopathy, you will have a murmur. Okay. What apart from that, more important than cardiovascular system?
Cranial nerve examination.
Cranial nerves, more important than that? Because you have 2 pathologies, sensory and cerebellar. You have to confirm sensory
Sensory, yes.
Yes, exactly. Yes. Position and vibration sense. It's very, very, very important. Okay. So you will say that I would like to check the position vibration sense, and then perform complete neurological examination of both upper limbs, lower limbs, as well as cranial.
Eye examination.
Yes. Okay, so most importantly, you will say, I will do the complete neurological examination of upper limbs, lower limbs, cranial nerves. Most importantly, sensory examination for position and vibration sense. Okay, very important. What other relevant examination will you do? Cardiovascular, you said, neurological, you said, what else?
For any organomegaly?
Yes, any organomegaly, any evidences of chronic infection in the form of ENT or just complete systemic examination if you have the suspicion of ataxia telangiectasia. Okay. So this was all about
Eye
ataxia.
examination.
Yes, eye examination is also important for ataxia telangiectasia as well as Friedreich ataxia, in which there is visual deficit. Okay. Now, eye examination actually comes as a part of cranial nerves examination, which you have to do. Now, as I told you already, two types of ataxia on the basis of broad categorization. How does the cerebellum and this sensory pathway take part in the balance and the keeping the balance of the individual? So what happens is there is position senses in the in the legs or in the feet, which pick up sensation and they go towards the spinal cord. Now this is the spinal cord. Now we're starting from here. Okay, they go towards the spinal cord, and then from there they travel in the spinocerebellar pathway up here, and then to the cerebellum. And in the cerebellum, actually, the cerebellum actually it is the central part for the balance. So it is actually this pathway that is responsible for the balance of the coordination or all these things. Now, some broad differences between cerebellar and sensory ataxia is that in cerebellar ataxia, you will have nystagmus, as I told you, dysarthria, I told you, dysmetria and dysstereokinesia we talked about, and intention tremor. These things you will not find in sensory ataxia. Very, very, very important. Okay. What will you find in sensory ataxia? The Romberg sign positive, which I told you already, and I gave you the logic behind it, and then again sensory deficit. Okay. Now I will quickly show you videos to do these examination if you guys are still left with any doubt. Okay, just give me a minute.
Several tests can be performed to assess cerebellar function. To check the gait, ask the patient to walk a few steps in a straight line and then turn and...
Ma'am, we're not seeing the video.
Yes, I understand. I'm just gonna share the screen for you. Just give me a minute.
Several tests
Now you can see it. Okay, so I
Yes.
showed you the sequence already. Now just because some of the things that it's better to see it and then appreciate. I told you the sequence already. Do the gait, do Romberg, check spine, make the child sit, eyes, upper limbs, knee jerk, make the child lie down, heel shin test, tone, and quickly check for sensation. Now we will check how these tests are done. Okay.
performed to assess cerebellar function. To check the gait, ask the patient to walk a few steps in a straight line and then turn and walk back.
Turning and walking back is very important. You can all hear it, right?
A wide-based, unsteady, and staggering gait is called ataxia and is typical of cerebellar disorder. To further challenge the patient's gait and balance, assess tandem walking by asking the patient to walk forward while placing the heel of one foot directly in front of the toes of the other. Perform the finger-to-nose test by asking the patient to extend their arm fully and then touch the tip of their nose and repeat the test several times as fast as possible.
Okay, it is important that they extend the arm fully.
Normally, the patient should be able to complete the task quickly and accurately. In cerebellar dysfunction, the patient would be unable to precisely place their finger on the tip of their nose and would either undershoot or overshoot. This is called dysmetria. In addition, if you observe a hand tremor that increases as the patient's hand approaches their nose, this is called an intention tremor, which is also a sign of cerebellar dysfunction. To further challenge coordination, perform the finger-to-finger test. Hold your index finger out at full reach from the patient and ask them to alternately touch their nose and your finger several times. Now move your finger to different locations and observe the patient's accuracy and smoothness of movement. Repeat the procedure with the patient's other hand.
This is actually the one you should be doing.
To test for rapid alternating movements, ask the patient to place one hand over the other and flip the top hand back and forth as
so you have
fast
to
as possible.
demonstrate it first. And
observe
then,
the accuracy, speed, and smoothness of their
and
movement.
it is very important that do it with both
An
hands.
inability to
Okay?
correctly perform
Because
this activity is called
first you have to use the left hand down and then move the right hand and then again do it, because if there is unilateral or if there is like one side cerebellar hemisphere lesion, then he can do it on one hand, but he cannot do it on both the other hand. So it is very important, finger nose test as well as this dysdiadokinesia. You have to do it with both hands. Okay, do it with right hand and then use his left hand. Okay, similar for this as well. Very important.
Diadochokinesia. Repeat the procedure with the patient's other hand.
Okay.
To test for the rebound phenomenon
This
of
is rebound
Stewart
phenomena.
Holmes, begin by protecting the patient with your arm and pulling their forearm away from them.
Okay, so you have to
Ask
protect
the
the
patient
child's
to
face.
resist as you continue to pull. Now abruptly release the patient's arm. Normally, the antagonistic muscles will stop the arm from moving too far towards the patient's body. In cerebellar disease, the arm movement will be excessive. To perform the heel to shin test, support the patient's
So the heel
leg
shin
and ask
test
them to
he's
place
doing
the
while
heel of the
sitting,
opposite.
but how are we supposed to do it? Anyone?
Sleeping.
While lying down. Okay. Yes.
The foot on the patella and slide their heel down their shin in
Okay.
a straight line
So you pick up his foot,
and then back up to the knee.
you put the heel on the knee,
Ask
you
them to
slide
repeat
it
this several
towards
Normally,
the
patient
foot
should be able
and
to
then pick
perform
it
this
up.
action
Okay.
smoothly.
So pick it up, make like a D and then put
The
it
patient
like
is
that.
unable to control the movement accurately. This is called dysmetria and suggests cerebellar dysfunction. Repeat the test with the opposite leg. This concludes our presentation of cerebellar function tests.
Okay. Now, I'll show you another video because one thing I wanted to show you. Romberg sign, guys, you know already, but let me share it with you again.
The Romberg test is used to detect the disturbance.
So you can
This
either
test is
extend
also
the
called the
arms
Romberg
or
sign or the Romberg maneuver.
roll them. It's the same. It's just supposed to test the
stand with their
balance.
feet together and arms folded across their chest. Remain close at hand in case the patient begins to fall. Normally, the patient should be able to maintain this position with little or no swaying.
Once you're doing the Romberg test, again, it is very, very important that you're standing next to the child and have both your hands on right and left side of him, not touching, but making sure that you're able to support once he is not able to maintain his balance, okay?
Now ask the patient to close their eyes. The patient should be able to maintain this position with only a small increase in swaying. If the patient sways excessively or begins to fall, it is considered a positive Romberg sign, indicating a problem with proprioception, either from peripheral neuropathy or a disease with posterior columns. To test for a more subtle deficiency of proprioception, a variation called the sharpened Romberg test can be performed. This test is also called the tandem Romberg test.
This one
In
you
this
can use.
variation, the test is performed with the patient standing.
Now let me show you another video just to show how past pointing is. So this is intention tremor. You see how his hand starts moving, but he's not he's not able to do two things. He's not able to touch his nose. Sometimes it goes here and there is also intention tremor going on. Understood? Everybody clear about this? Any query or any confusion left in cerebellar examination or ataxia examination, let me know. Now we will come towards our case, all right? The case that we were discussing. So the case that we had was what? So this is our case actually. Let me share the screen with you guys.
Gait requiring assistance to walk. This display is a characteristic wide-based gait requiring assistance to walk.
Okay, so this is our 15-year-old. She's actually a bit older, but
She
this is
also
actually
has
the
a
case.
bilateral foot drop, which is related to
So what is going on? Wide-based gait,
Mrcpchfop.
not able to complete balance, sort of like a drunken gait, and a bit of foot drop because there is sensory pathology going on as well. Okay, after that, you see the nystagmus, subtle nystagmus as well. Okay.
Rapid open, close hand movements and finger tapping movements are mildly slow but not ataxic. Supination, pronation movements of our hand
This is
are mildly.
stylokinesia. They are not very good coordinated movements. You can see it. They forget about the technique in this. We're just showing you the signs here. Okay, see?
Target.
You see the intention tremor and a bit of past pointing? Not very smooth.
And looking at her feet, she displays pes cavus bilaterally.
Okay, what are the findings in the feet? What is pes cavus? What is pes cavus, Dr. Geeta? Okay, so this was all about our case. Okay. Now, now who can summarize this case for me? Anyone? Increase arching of foot, yes. Okay, so first tell me, Frederick ataxia is sensory ataxia or cerebellar ataxia? Who can answer this question? Guys? Wild guesses, no worries. Either write in the chat or open your mics. Frederick ataxia has cerebellar ataxia or sensory ataxia?
It's a sensory ataxia.
Okay.
It's sensory.
Then why is there past pointing and dystokinesia?
Means
Okay.
both of them.
So the answer to this question, very good, Dr. Nuzul, it is a prototype, both sensory and cerebellar ataxia. That is why it is very important. And that is why I've actually brought this one for you. It is the case in which you will get both sensory ataxia findings as well as cerebellar ataxia findings. We just discussed in the slide here that sensory ataxia has, where is it? Sensory ataxia has nystagmus, dysarthria, dysmetria, dysdiadokinesia, and tension tremor. Sorry, cerebellar ataxia, and sensory ataxia has sensory deficit as well as Romberg sign positive. Now, in Frederick ataxia, it is one of the cases or one of the diagnoses in which there are mixed findings, very, very mixed findings, like we had in our case. So how are the findings mixed? The reflexes, this is the only diagnosis or only disease in which there are mixed even upper motor and lower motor signs. So how are they mixed? Can anybody tell me? Reflexes are decreased, tone is increased, and plantars are upgoing.
There will be positive Babinski sign.
Yes. Plantars are upgoing, but at the same time, there will be hyporeflexia. So whenever plantars are upgoing, there is hyperreflexia. Remember, right? The clonus is positive and there's hyperreflexia. But here, clonus was negative, reflexes are decreased, but at the same time, there is upgoing plantars. What is the reason for that? Because reflexes have a sensory pathway and a motor pathway. There is sensory deficit here. So the reflexes are decreased. Okay. So very important. This slide is to show you certain things. Once you have an ataxic gait, you do Romberg sign. Romberg sign will tell you if it is cerebellar or sensory. If it is positive, okay, then you have sensory pathologies. So what are the sensory causes of sensory ataxia? Number one is Friedreich ataxia. What is the second one?
Peroneal muscle atrophy.
Yes, non-muscular atrophy, any peripheral neuropathy leading to sensory deficit.
Vitamin B12 deficiency.
Vitamin B12 deficiency, ataxia telangiectasia. These are causes of sensory ataxia. What is the causes of Romberg sign negative cerebellar ataxia?
It could be acute cerebellar ataxia or chronic cerebellar.
Cerebellar pathology, any cerebellar pathology. It could be acute, it could be chronic, it could be infectious, it could be inflammatory, it could be a tumor, space occupying lesion, hemorrhage, anything. If you, a good way to remember any pathology, if you cannot think of any reason, is remember HIT. So H is for hemorrhage, I is for infection as well as inflammation, T is for tumor as well as trauma. Okay, so hemorrhage, any intracranial bleed involving cerebellum, you will have cerebellar ataxia. Any I is for infection. So which infectious pathology leads to cerebellar ataxia? Most common. You guys, I think, mentioned it.
Chickenpox.
Sorry. Yes, post varicella. Post varicella, varicella cerebellar ataxia. Okay, so I is for infection as well as inflammation. If there is any acute demyelinating encephalomyelitis, like any inflammatory procedure pathology going on involving cerebellum, it will lead to cerebellar ataxia. And again, tumor, T for tumor. Okay, so this was for the cerebellar pathologies. Where is it? Here. Okay, so it could be ataxic cerebral palsy, posterior fossa or cerebellar tumor, and could be infection, it could be hemorrhage, anything like that. Okay, now we will come towards our case. What is the inheritance of Friedreich ataxia? It is an autosomal recessive disorder, leads from mutation in chromosome 9 and Friedreich's gene. It is an autosomal recessive disorder. What are the symptoms? It has a very multi-organs presentation, okay? It can lead to scoliosis, it can lead to cardiomyopathy, it can lead to pescavis, it can lead to learning deficit, like it is obvious in this young girl. It can lead to visual and hearing problems, as well as endocrine problems in the form of risk of diabetes. Okay, how will you investigate? The definitive investigation is, of course, the genetic test for mutation, but you have all the supporting evidence like echo, ECG, visual evoked potential, and all these things for as a supporting evidence for your diagnosis. How will you treat? It is a multidisciplinary approach involving physiotherapy, neurology, orthopedic surgeon for scoliosis as well as pescavis, cardiologist if the cardiomyopathy is there, occupational therapies if there is any severe, a malfunction in performing the daily activities, and speech and language therapy if these are involved, as well as endocrinology if there is diabetes. Okay, other broad categories of ataxia: if it is acute, it could be any related to drug, any infectious cause, recurrent causes or metabolic, and progressive can be cerebral palsy as well as other neurodegenerative disorders. All right, so this was all about ataxia. any questions, let me know. I'll take a moment to give a short introduction about our course. We have a very extensive course composing all the stations for the Mrcpch clinical exam. There are long and live sessions followed by immediate availability of the recordings, which you can have access to for unlimited time. I mean, until you clear your exams. And yes, if you have any queries, let me know. Otherwise, we'll call it a day and we can close our session. Okay, I hope it was clear to you. I hope you guys learned from it. And thank you very much for all being here.
Ma'am, is the batch already started?
Actually, the current one is about to end. The next one will start in August to September. But you can message any queries in the group. They will get back to you. All right.
Okay,
Thank you so much, everyone.